Klaudia Shenton is the Strategy and Policy Manager with the Aboriginal Health Council of WA. Klaudia has worked in various policy and research roles, focusing on issues related to human rights, asylum seekers and international development. We're fortunate to have heard Klaudia speak at the WA Collaborative Commissioning Partnership Forum on the topic of closing the gap and the associated reform priorities.
I think life expectancy is shaped by, so many social, cultural and health factors. So we need a coordinated response in WA to tackle that. I think first we must strengthen comprehensive primary healthcare delivery by Aboriginal community controlled health services. We know that arches consistently deliver better outcomes purely because, they are culturally led, the care is continuous and it's driven by local community need and local community priorities. I think secondly, we need to tackle the major determinants of life expectancy. So that's housing, environmental health, mental health, chronic disease prevention and EOD support, because these areas significantly influence well-being well before someone becomes unwell. I think thirdly, continuity of care is critical, because whether an Aboriginal person is in hospital or back on country and in community, their care shouldn't be fragmented. And that includes transitions of ITC funding, move into the arches sector, so navigation and chronic disease management can actually be provided by trusted providers to the Aboriginal people and their communities. And I think finally we need to be accountable to the National Agreement on Closing the Gap, and that means commissioning services with and through ACOS and ensuring that there's actually long-term, flexible and sustainable funding. And I think if we get these structures right, we will not only improve life expectancy, but we will improve it in a way that's culturally led, culturally safe and community driven, and that will make it sustainable, I think, for generations to come. Priority Reform 1 is all about shared decision making and genuine partnerships, and collaborative commissioning really gives us a very practical and real way to implement this, not just by inviting ACOS to the table, but actually having joint, setting priorities jointly, designing models and determining how resources and funding is allocated. So it really shifts us from that consultation piece to true co-ownership. And then Priority Reform 2 is all about building and strengthening the Aboriginal community controlled sector. So for commissioning to really succeed, ACOS must have the authority and resources to lead service delivery and co-design how that service delivery should look like. This includes, again, transition like ITC funding and broader reforms where ACOS are recognized as the preferred providers. And I think together these reforms will allow collaborative commissioning to be more than just a project. It will be a structure for systemic change. And when government, both national and state government, mainstream providers and ACOS share those decisions and strengthen sector capability, we can again create a health system that is responsive, culturally safe, and genuinely aligned to closing the gap. So really these two reforms, Priority Reform 1 and 2, aren't optional when it comes to collaborative commissioning. They are the mechanism for lasting change.
Thanks, Klaudia. And I think if we take from hearing from Des Martin, CEO of ACWA this morning at the Partnership Forum, how we do this work, how we work towards those priority reforms in the spirit of trust, authenticity and genuine partnership, I think is really, really important.